So, Professor Weiss, welcome. Let's discuss now the ICU care pathway with short and long-term planning, the patient specificity, etc. What about daily routine at the bedside and long-term planning with ICU outcomes? A very important topic, and you are well placed to discuss it. And as mentioned, you are from Berlin. So welcome, Professor Weiss.
Thank you very much. And thank you very much for switching in and listening to the ICU care pathway, which I'm going to talk about in the next 17 to 20 minutes. So, what are we going to talk about? We are going to talk about the ICU care pathway, the short and long-term planning, the patient specifications, and we will focus on two topics. The first topic is going to be the daily routine at the bedside of ICU patients and setting the plan of the day. So a very important topic, what are you actually planning for a day? And the very important question, why do you have to plan every day? And then the long-term planning, ICU outcomes, and how to avoid failed functional outcomes. And I would like to start the story with the very end and looking a little bit about outcomes and functional outcomes after ICU. So actually, if you come to the ICU and you're not an intensivist or an intensive care nurse, you will probably think there are only two possible outcomes. So either the patient survives the critical illness or the patient dies. But this is actually not the whole story. ICU survival, or the probability of survival, looks more like shades of gray, if you want to say so. So actually we have, it's a very, very easy and a very simplified graphic now, plotting all the patient characteristics and the severity of illness to a two-dimensional scale. But you actually have patients that are very, very unlikely to survive and those that are very likely to survive. And the probability of survival actually depends on the care. And the care has changed. I want to show you one graph here from Kirsi Kaukonen from the JAMA from 2014 about sepsis survival. And you see that between 2000 and 2012, there was a significant reduction in mortality of these patients. So we actually became better in our care. And what does this mean in this graph? It actually means that we shifted the survivability of illness from here to there. And the question is, what kind of survivors do we find, especially in this cohort? So in the cohort of maybe patients that would have not survived in 2000, but that survived in 2012. And if we look at these patients, they have functional characteristics and impairments that are unusual. So we also talk about a so-called new cohort of ICU survivors. I brought you a picture I got from the internet. There is a lovely blog called The Art and Science of Delirium, and this is a picture drawn by an artist who survived critical care. And I think this picture tells more than 1,000 words, because these are typical functional impairments patients are suffering from after the ICU. It's a lot about mental illness and cognition. It is a lot about problems with muscle function and problems with neuropathy. And it's a lot about functional independence. So the question of whether a patient is able to walk again or not. So I get you the laser pointer. It's easier to see then. She wrote under this picture, learning to walk again. So to put it in numbers, and if we are looking at patients that we are caring for at the moment for COVID-19, so really severely level 3 patients, as you have heard previously in a lecture, you will see that these patients have a high likelihood, between 45 and 70%, of having a kind of cognitive disturbance after critical illness. 30 to 75% suffer from immobility. 10 to 60% have mental health problems. And this does not only mean post-traumatic stress disorder, this is probably the most well-known one, but there are also others like, for example, the dependence on psychoactive medications due to depression or anxiety. And 5 to 10% of the patients are actually chronic critically ill. And what does this mean? This actually means that patients cannot leave the intensive care unit environment, but they are chronically dependent on organ support. So they're long-term ventilated, they're long-term dependent on monitoring care because they have continuous problems. And especially these three entities we call post-intensive care syndrome, after a consensus conference by Elliott and colleagues a couple of years ago. So there is something like a post-intensive care unit syndrome. And if we go back to the work of Kirsi Kaukonen, we see, it's from Australia and New Zealand, and we see here that what you actually see is there is a new cohort of ICU survivors that builds mostly of these patients that would have not survived a couple of years ago, but do now survive. And if you go a little bit more into depth of the paper, you also see that the likelihood of these patients being discharged home, if you compare here 2012, this is the bottom one, to 2000, you see that the likelihood discharged home, not being discharged home, being discharged to a nursing facility or to an acute care facility increases by time. So we allow more severely critically ill patients to survive, but there is also more functional decline. And this mandates that we also focus on this. So we learned about functional outcomes now and ICU outcomes, and we are going to go later into the question, how can we avoid these failed outcomes, and can we avoid it at all? So now let's look at the first point, the daily routine at the bedsides. And I want to take you to the ICU actually, and it's 7 a.m. in the morning. This is a specific of the ICU. We usually start very early, and this is a picture of pre-COVID times. You see it, we're not wearing any personal protective equipment, but just our scrubs. And you see here a multidisciplinary team. We all look the same on the ICU, which is also a specific of the ICU. And you see nurses, you see allied healthcare professions, you see Professor Weber-Carstens, our leading head consultant, and myself, I'm an intensivist being on the ICU. And we do what at 7 a.m.? We do the handover from the night shift to the day shift, but we also do a very important second thing. We set daily goals for the patient. So what happens at 7 a.m. in the ICU? At 7 a.m. in the ICU, when we have a handover from night shift to day shift, the multidisciplinary and interprofessional teams meets at the bedside. We do a short summary of the patient and the problems. So we recall what kind of patient is this, a patient with respiratory failure due to COVID-19 infection, for example. And we memorize which day of the ICU treatment it is. And then we give a short summary of the night. So what has very recently happened. And then we set daily goals for the patient. And who is there, or who should be there? It is not only the physicians. It's not only the physicians, but it should be the bedside nurse, it should be the physiotherapist, it should be the AHPs, the treating physicians, and the intensivist, of course. So it should be a team of all people taking care. If you think about the time the intensivist spends for one patient, if the intensivist has to care for 20 patients, it's roughly 5% of its daily time, given that there was no kind of paperwork that has to be done. The the intensivist could stay at one patient's bedside. But the bedside nurse who's treating for 2 or 3 patients spends between 50 and 30% of the time with a patient. So it's very important that you have all parts of the team being there, and especially those parts and those members of the team that deliver most of the care. So this is really a very important and crucial point for me, that all members of the team are gathered around the bedside. Yeah. What are my tips for this first round? The quick tips. If you are there for the first time, make sure you know who is who, because it's not very easy at the beginning to come in a big ICU team of 20, 30 people you probably don't know if you come from outside, and if you're a surgeon or a dermatologist or internal medicine specialist, and make sure you know who is who and who has which responsibility. Make sure you understand each other, especially in COVID times. It's difficult to understand people because you're wearing this personal protective equipment, and the acoustic is not so easy. Be at the bedside of the patient. This is my recommendation. Put on the PPE and go to the bedside and make the handover at the bedside. Don't do it remotely, because you have to see the patient and you get a lot more aspects involved. And then be especially aware of hygiene aspects as you move from bed to bed, as these patients on the ICU are really frail and highly susceptible to get iatrogenic infections. So the last point is really not the least one, but probably the most important one. Be very concentrated and concise, because ICU can be very stressful. No day is like the other, which is like definitely for me one of the most attractive things about ICU, that it's really challenging and that it's really a very, very great and very good task you have to do, but you need to be concentrated and concise. You cannot talk about one thing forever. And if you start, maybe you would consider using a checklist. I don't want to go through this checklist with you, but I want to tell you there are checklists, and the intensivists of your ICU that are there will probably have already made a checklist for COVID, and I suggest that you use it. I don't want to go into details with evidence. I used this checklist from a paper from Yi Rim Chang and colleagues from the Journal of Trauma and Injury from 2017, just to give you an idea how this checklist might look like. But there are several, if you're interested, there are several trials, and one is a nice one from the BRICNet from Brazil, a cluster randomized trial on the effect of quality improvement on intervention with round checklists and goal settings. And they actually failed to show their primary endpoint, that the mortality decreased by it, but I think they showed something really important. They showed that the teamwork aspects are improved and the safety climate is improved. And I think these are very crucial things, especially if you're new on the ICU. And I remember my first day on the ICU, safety climate is a very crucial point, because at the beginning, you feel quite overwhelmed by all the different machines and the syringes and the medication, and a safety climate and something that gives you some kind of hold can be very important. I put some further readings here, so if you're interested, you can read a little bit about checklists and quality indicator and goal setting in the ICU. So if you define daily targets, which typical domains should you consider? You should, and this is also a difference to normal medicine, if you want, so level 0, 1, and 2 care, you should always consider the whole patient. A critically ill patient is sick from head to toe. It's not only one organ system, but you have to take into consideration many aspects. Mechanical ventilation and weaning is something that frequently happens to be a daily target. Anti-infective therapies, nutrition, digestion, energy, metabolism, diagnostics, so MRIs and CT scans that can be very laborious, especially in PPE, therapeutical interventions that have to be done. The fluid balance is always a topic. And of course, family and talking to relatives should also always be considered when setting daily targets. Plus, and I said that here, always ABCDF. So you always should use some standard mechanisms, and you learn about these in other sections of this online learning program, but I will come to a very brief explanation of this later. There are some things that every patient should get every day. So daily targets, what are daily targets? Actually, if you want to climb a mountain, and critical illness for the patient is definitely like climbing a very high mountain, you cannot do this within one day and one step, but you need many steps. So, and it's a very, very challenging pathway for the patient. So I suggest to go the only way to get there is going little steps and making also progress from camp to camp. If you want to climb Mount Everest, you can't do it in one day. So it makes sense to have a long-term aim in your head, for example, weaning the patient from mechanical ventilation, but you cannot get there from one day to another in many patients, but you have to go stepwise. So daily targets are usually 1 to 3 targets per patient. A target should always be measurable or doable. You should write the targets down in a checklist or EMR and make them visible for the team, so it should be clear where you find them. You must make sure that all team members and you, especially you, understand the targets, and you have to make a plan for the day. What should be done, who should do it, when should it be done, where and which outcome do you expect from it, and never make standards a target, because standards are standards and every patient needs them every day. So I give you an example and you can decide if it's good or bad. 32-year-old patient, COVID-19, 7 days since symptom onset, dyspnea since 3 days, second day on the ICU, is now on high-flow nasal oxygen, FiO2 is 0.55, so 55% oxygen, and gets dexamethasone. And you want to have daily targets. This is a very, very short epicrisis. There is much more to consider usually, and I found these targets. It's a real case. Improvement of respiratory situation, negative fluid balance, and standard lab. Do you think they are good or bad, if you recall it? I think they're maybe not bad because they have good outcomes and good intentions, but I think they could be better because you don't know what is my to-do here, how much negative fluid balance, and how do I achieve that, and what is my standard laboratory. So it's better to make it very specific. You, for example, say, I want to improve the respiratory situation and guide the patient for self-proning to get an improvement of respiratory situation, and this will be done by Dr. Miller. I want a negative fluid balance of -500 to -1,000 milliliters, and this is going to be taken care of by the advanced critical care practitioner, Ms. Jones, and I want the COVID standard lab, which is set number 2 in the lab channel, and the bedside nurse is going to prepare this for us. So then you can really have a checklist and check, did you get the targets accomplished? And they are never carved in stone. The situation in the ICU changes every day and changes very rapidly, so you should make sure that you're able to be flexible. If this patient, for example, the 32-year-old, I remember, deteriorates within 2 hours, then you have to intubate them and you cannot go for proning. And this is an extremely important message from me, that you have to communicate and that every team member needs to be alert. And if you think something is wrong, you should always talk to the intensivist or the supervisor. So now we learned something about daily routine at the bedside of the ICU patients, and especially the beginning of the day and setting the plan of the day and being flexible. So what about long-term planning and how to avoid failed functional outcomes? The long-term planning usually is clear. It's full recovery, functional independence of the patient. And I suggest to have weekly targets for every patient. So that's very easy to say. But how do we focus especially on the post-ICU period? And I suggest you, if you're interested in this web page that is called icudelirium.org, it's from Professor Dr. Ely from Vanderbilt University. I accessed it the last time 2 days ago, and it says the classic care of critical ill patients, they quoted there on the website, is similar to a dementia factory. It's up to us to close this factory. It's from Dr. Raul Alejandro Gomez from Buenos Aires. It's a very strong quote, but what this quote wants to say is actually that there is something we can do for the patient to probably enhance functional outcome and make an intensive care stay less traumatizing. And this is what I wrote before the ABCDF. And I try to very, very briefly just explain to you what is the ABCDF, and I slightly modified it for non-ICU staff for the COVID-19 space. The A is avoid heavy sedation whenever possible and manage pain. There is a lecture on this where you will learn how to avoid heavy sedation and make sedation only when it's necessary and try to keep the patient awake as soon as possible. Breathing without a ventilator is very important. There are situations where the patient needs really a mandatory ventilation. That's undoubtedly the case, and spontaneous breathing is not always good. There is a lecture where you learn about spontaneous breathing trials, readiness to wean and weaning criteria, and where you learn when a patient should breathe and when not. The choice of drugs is extremely important. In the ICU, patients get a lot of drugs, and especially a lot of antibiotics, and you have to be very careful. And you have to be careful to wisely choose them, and I suggest that you consult an intensivist if you're unclear about the medication of a patient. You learned about fast hugs already in this module, so I'm very sure this gives you a very good start to do a good medication for the patient, and do not forget domains. The delirium is a big problem, and there is a lecture on delirium. Delirium is the special kind of confusion which is characterized by inattention, so it's a patient that is not acting normal, and these patients need specialists because there is a cause for it, and you need to evaluate that. Exercise and mobility, and I tell you also the very small steps are steps, so there are, compared to normal wards and acute care wards, of course, limited possibilities of mobilizing a patient. So the patient will, in especially a COVID ward, probably not run around, but you will have the possibility of moving the patient, and even lifting the arm activates muscles. And of course, you see that A and E are very closely related. And family engagement and empowerment via tablets, smartphones, and phones, that is something we had to learn, we intensivists had to learn during the crisis as well, is a very important point. So this is the homepage where this is a little bit more elaborated. So if you want to do some self-study there, of course, you're more than welcome. So we learned about daily routine at the bedside of the ICU patients, and we set up the plan for the day. We did some long-term planning now, ICU outcomes and how to avoid failed functional outcomes. And I introduced the ABC A to F bundle to you. And I sincerely hope that you and your patients will climb the mountains together. I'm very, very optimistic. I wish you best of luck for the period. I wish us all best of luck. Stay safe, stay healthy, and I hope that you will appreciate your time in the ICU. And thank you very much for your attention.
Thank you very much, Professor Weiss. I think this was excellent and very informative. And indeed, as you emphasized at the beginning, the outcome from the ICU stay is not black or white, and we need to think at the quality of life after the ICU stay. And I think one of the most important elements there is to try to avoid sedation. You mentioned that, but I still hear people saying COVID-19, they all need to be sedated on respirators. But we have patients with COVID-19 or other diseases who can be maintained by mechanical ventilation without any sedation, and the long-term outcomes, now it's well established, are much better when you can do without it. I know there will be another discussion of sedation, but since we speak here about long-term outcomes, we need to perhaps emphasize this point. What do you think?
I think I couldn't agree more with that, because there is evidence that has been emerging over the last 20 years that actually very clearly showed that in terms of sedation, less is more. The patient needs to be without pain, and the patient needs to be without stress, but the patient does not benefit from heavy sedation. This is clear since the end of the 1990s, actually, and it became more and more evident and more clear. And I saw that with a little bit of trouble that during the COVID pandemic, we sometimes forgot a little bit about what we learned in the last 20 years, and we fall a little bit back into this time where heavy sedation and paralysis was like a standard of care. So I really can recommend the module on sedation of this learning module, because I think it's very important that you learn on how to efficiently avoid sedation. And let me add one thing. Deep sedation does not mean that the patient necessarily has less ventilator dysynchronicity, as we call it. So the patient is not adapted better to the ventilator via sedation, because deep sedation can lead to reverse triggering and to things that actually lead to a worse situation on the ventilator for the patient. And of course, it's linked to a lot of problems like delirium, a prolonged period of immobility, probably the loss of muscle and other things. So I think it's really important to focus on these aspects. And as soon as you start ventilating the patient, you should think about how to wean the patient from the ventilator again, with the intubation actually.
Yeah, as you indicate, sedation may promote delirium and may promote prolonged weakness. So when should we really start physiotherapy and try to improve functional outcomes by early mobilization?
I think there always is this day zero on the ICU, where the patient deteriorates and where the patient is intubated. And I think on this day, you set the plan for the next week. And if the patient is highly unstable and the hemodynamics are unstable, of course, this patient will not benefit from moving around on the ICU. But as soon as the waters get a little bit more calm, which is usually the case within 24 to 48 hours, you definitely should start physiotherapy. And you should use a protocol there and should try to get the patient sitting on the bed. And this is also possible when the patient is intubed. So you should definitely not wait until the patient is extubated, because you will have a lot of struggle if you keep the patient sedated for days or weeks and then try to mobilize the patient. You will see that there is no more strength of the patient. So you should use as much as it's safely possible as early as possible. And sometimes it's really possible, and we made this experience with COVID patients here in our institution at the very beginning. As soon as the patient has been prone for 3 times, afterwards, when the patient is in the supine position again, you can easily get the patient awake, and the patient can move the arms, and the patient can sit up in the bed, and then the patient can sit on the side of the bed. So these are the steps we usually take, and we should take them as fast as possible. But it's really important to also acknowledge and appreciate the small movements of the patients.
Very good. I cannot agree with you more. I think these are really excellent points. Now, some people may argue then when there is a surge of patients, they have no time to do that. And it may actually lead to the option of calling physiotherapists from other departments in the hospital to help in the ICU. But people should probably know that this is important and we cannot wait, as you say.
You agree? Wait. I agree fully. We cannot wait. We need physiotherapists.
Now, I like your daily plans, of course. I think it's really very, very important. But I find it difficult to be precise, and you alluded to that. But knowing how much fluid the patient should lose during the next 24 hours, perhaps it's possible when the patient is stabilized and ready to leave the ICU. But otherwise, it sounds like the surgeon coming in the ICU in the morning and saying, this patient should lose at least 1 liter of fluid today. Okay, I'll come back tomorrow and check. Well, there are so many things that happen during the day. It's probably better to monitor the patient as we do and try to personalize our therapy throughout the 24-hour period. Don't you think?
I absolutely agree that we should adapt to the situation every hour. And especially when it comes to fluid balance, we sometimes think the patient has edema, would benefit from a loss of fluid. But in the end of the day, we see the patient gets a bacterial superinfection, and suddenly we have plus 3 liters, which the patient required at this day. So this means not that you have not fulfilled your daily target, but it means the situation has changed. And you are aware of this. I think this is the important point.
Yeah. Now, I agree with the use of checklists, and we heard about fast hug with very specific item to be followed. Now, you mentioned that the goals should be quite precise and specific, but then you alluded to an ABCDE checklist where the C is just the choice of drugs. So should I ask people in the ICU, please go to the C and make the right choice of drugs? They will say, yeah, of course, that's what we do. And we may rediscuss antibiotic therapy today, by the way, but it's so vague. What do you mean by choice of drugs? So are you sure that this kind of checklist is very helpful?
The choice of drugs, yeah, I think if you look at the amount of drugs patients get and the let's say the choice of drugs is the link to the fast hug. Let's put it like this. I think this is a good link to the fast hug to look, does the patient has the drugs that the patient requires, and what is like the excess of drugs. For example, a patient that is very hypotensive probably doesn't benefit from getting its antihypertensive therapy, you know. But a patient that is on, let's say, a beta blockades and is beta blocked would probably not benefit from abruptly stopping them. So it just means for me that you have to check the medication carefully every day. And I have seen the phenomenon several times that medication is, let's say, a couple of medications just run through the treatment of the patient and are not stopped in an adequate manner. Antibiotics are given far too long. Sometimes anticoagulation is stopped because you want to make a procedure and you need to stop it, and then it's not started again. And so this is really important to look at the drug sheet of the patient every day and to recall the checklist every day. Does this patient have the proper anticoagulation? And especially in COVID patients, anticoagulation is a very big point, and things like that you should not forget about them. So I think having an extra look on the drug sheet, and I know there's also a chapter on pharmacotherapy in the ICU here. I think that's a very important point.
Super, Professor Weiss. This was very informative and very well presented. Thank you very much. Dankeschön.
Dankeschön. Merci bien.